welcome to Psychiatry Boot Camp Season 2, Hoofbeats on Broadway. I'm Dr. Mark Mullen. This season, we are going to go horse by horse through the psychiatric stables to learn some fundamentals of various psychiatric diagnoses. But first, as with last season, we're going to set the stage by contextualizing psychiatric diagnosis. So our job as psychiatrists is not simply to look at a list of checkboxes and then place a human being inside of those checkboxes. We need to think really critically and deeply about what exactly we are doing when we make a psychiatric diagnosis. And who better to help us do that than Dr. Alan Francis? Dr. Francis was chair of the American Psychiatric Association's DSM-IV task force, and he is the chair emeritus at Duke University. Dr. Francis is graciously joining us again this season, and I truly could not be more excited. This episode title is a nod to his published book titled Essentials of Psychiatric Diagnosis, and I cannot recommend it highly enough to anyone who wants to explore the topic a little bit more deeply. So without further ado, welcome back to the podcast, Dr. Francis, and we are so happy that you are joining us.
Well, always my pleasure, Mark. You're one of my favorite people, and I think that the work you're doing is absolutely crucial to improving residency training in America, so carry on.
Well, that means the world to me. So you're one of the world's, if not the foremost experts on psychiatric diagnosis, and you begin your book, Essentials of Psychiatric Diagnosis, by discussing and labeling a concept called stepped diagnosis. What is stepped diagnosis?
One of the great problems now is that most psychiatric diagnosis is done after very, very short visits. So actually 80% of psychiatric medication is prescribed by primary care doctors, usually after 10 or 15 minutes. The patient's been primed by TV ads and their friends to ask your doctor about antidepressants or anti-anxiety drugs. The doctor wants to get the patient out of the office really quickly. The most efficient thing he can do is write a prescription, he or she. It's equally true that for psychiatry, the evaluations have been shortened over time and the contact with patients made much less. This is largely under the pressure of insurance companies. And so the patient often comes to the psychiatrist only because they're expecting a prescription, nothing else. And it's almost like an automatic. Everyone will be surprised if the patient doesn't get medication. The trouble with this is that most people who present for a transient problem, milder psychiatric symptoms that haven't lasted very long, most will get better on their own. If you look 6 weeks later, most people are presenting at the worst moment in their life, just regression to the mean placebo effect of the appointment, that most people coming for a first session with a primary care doctor will get better on their own, or will get better with advice, with normalization, with psychotherapy. And this push to diagnose quickly, largely driven by insurance companies and the fact that doctors don't know their patients, and to prescribe quickly, that leads to much unnecessary prescription. And once a patient gets the medicine, 2 weeks later, when they're better, they don't realize that they're better because of regression to the mean and the passage of time. They think the medicine worked, and they'll often stay on it for decades. Unnecessary medicine with side effects for decades, when it would have been much better to take more time up front to make sure that a diagnosis is necessary and the treatment's necessary. And so the idea of step diagnosis is you shouldn't be making diagnoses in first sessions. Diagnoses should be written in pencil. There should be a period of evaluation time with normalization of the symptoms, advice about ways of dealing with it, mobilizing support, psychotherapy. All of these things coming before a diagnosis would eliminate the need for any diagnosis, any treatment later on. The system doesn't allow for that. But people working within the system should feel badly if they jump to diagnosis, should not be quick to start medication. And watchful waiting is the most important tool that's not being used these days because everyone feels like they have to jump. How to deal with the insurance companies? Underdiagnose. Give the least damning diagnosis. Once you put a diagnosis on the chart, realize that it won't be written in pencil. It may last a lifetime. That diagnosis may haunt the person later on in life. They may have trouble getting insurance. They may have trouble getting a license to fly a plane. They may have trouble in custody battles. You don't want to put a diagnosis on the chart unless you're very sure of it and it's absolutely necessary to have that diagnosis. So it's always wise to underdiagnose, and whenever there's a toss-up question, should I give this diagnosis or not give this diagnosis? Don't. Give a lesser diagnosis. The way of looking at this is utilitarianism. Will the diagnosis benefit the person more or harm them more? And when you only know a patient for a few minutes in the first session, you always have to worry about the unintended consequences of the diagnosis later on in the person's life in terms of overtreatment and all other sorts of stigma that can come with it. So the key in the situation where insurance governs too much of our behavior is to be very cautious in giving severe diagnoses early on before you really know the person. And this is particularly true in children because they change so much developmentally. At least half the kids getting a diagnosis of ADHD may just be immature and less able to function in the classroom. And don't jump to that diagnosis early on because it can have consequences later on. Also in the elderly, where medical problems and medication can be such an enormous, the first thing I always think about with an elderly person who comes in with a new symptom is medication. The second thing I think about is medical illness, neurological problem. Don't jump to a psychiatric diagnosis with anyone, but especially with younger kids and with older adults.
So you're reminding us that as physicians, we have a lot of different entities that are trying to influence our behavior, trying to govern us. But our responsibility is strictly to our patient, always to do what is in the best interest of our patient, regardless of the kind of external pressures that we feel exerted upon us. And then when thinking about making a formal diagnosis, which can really change the way someone sees themselves, thinks about their self-efficacy, their relationships with other people, the medications they might need, making sure we are ruling out medical problems, ruling out normal human functioning, writing diagnoses in pencil, and then not making that firm psychiatric diagnosis until we're absolutely positive.
Yeah, in other words, it's always, almost always in the best interest of the patient to be cautious and slow in making the diagnosis of a severe disorder. The exception to this, of course, is the emergency room and people who have long-standing, very clear-cut, severe psychiatric problems where quick diagnosis and urgent treatment is called for. But that's the minority of people we see in average everyday practice.
So I think that most people come to psychiatrists because they feel like something is wrong with their mental, emotional functioning. And most commonly, we are indeed conducting an interview, making a diagnosis, prescribing a treatment. And it's clear that that can be healing. I mean, we have eons of randomized controlled trials to verify our psychiatric treatments that have been approved by the FDA. But you also seem to think that simply normalizing a patient's distress can also be healing. You don't think this would be, to use the kind of fad pop psychology term, gaslighting the patient, saying, oh, you're okay, you can handle it. I know you think that you need my help. I know you think you need a medication, but really, this is normal human functioning. You can handle it. How are these things different?
Well, I think that, again, we have to distinguish the people who are really sick and have very severe, urgent, sometimes emergent mental health problems from people who are coming to a primary care doctor or psychiatrist with a transitory problem that hasn't been around for that long, hasn't caused that much impairment or distress. For the people who are really sick, we have to provide treatment quickly. We can't neglect them, and we shouldn't be shy about diagnosing and treating vigorously. But for people coming with more stress-related problems, and that's very frequent in average everyday primary care and even in psychiatric practice, the realization should be that not every emotional distress is a mental disorder, that unpleasant emotions and even at times maladaptive behaviors happen under stressful situations, happen when someone loses a job, when wife or husband says, I want a divorce, when kids are having trouble, and especially these days with terrible financial problems that people live with poverty, with the inequality of resources that people have to face, that we shouldn't assume that every time someone has a feeling of depression, panic attack, anxiety, that this is necessarily pathological. In many instances, the symptoms serve a purpose or are a useful marker that this person needs help, not necessarily that they have a mental disorder, but they need help with their lives. And I think that talking to people about their symptoms, and the more you get to know a patient, the less likely you are to jump to a diagnosis. The more time that a clinician can really get into the patient's life and understand the context in which the symptoms occur, the more sensible those symptoms seem. The less likely it seems, oh, they have a mental disorder. I'm facing these 9 things in my life. I'm not sure what to do. It seems much more normal once you know about those 9 things in the person's life, but that takes time. And the problem with step diagnosis, the reason it's not done more is that it takes upfront time to really get to know your patient. Time in each session, it's hard to do in 10 minutes, and time over months and weeks and maybe months before a clear picture emerges. The problem with our system now is that we force an uploading of diagnosis at the very beginning in order to get reimbursement. And that prevents us from actually what would be a more cost-effective approach of not requiring long-term treatment because we do what's right at the beginning. If you don't handle the beginning part of a contact with a patient well, if you put them on medication after 15 minutes, they may be on medication for life that they didn't need. The system now does not allow adequate evaluation and adequate psychotherapy at the very beginning, which would obviate the need in many people for longer-term treatment that's way more expensive and way less useful for their needs.
One of your pieces of advice is to make diagnosis a team effort. But isn't my job to evaluate the patient myself and make a diagnosis? I mean, isn't that why they come to me, because I'm the expert? How would you recommend involving a patient in the diagnostic process?
Well, I think a team effort really extends not just to the patient, but also the patient's family, the primary care doctor, the social worker, in some cases, the teacher. One of the things that's very clear from experience and from the literature is that no one source of information is ever complete or completely accurate. The different sources of information will give different information, and that the clearest picture will come from putting together a 3-dimensional or 4-dimensional or 5-dimensional view of the patient by getting information from various sources. The chart can be helpful. The trouble with the chart is it often has vast inaccuracies, because many people seeing the patient over time have overdiagnosed the patient before. So you need to review the chart carefully. The chart's part of the team in making a diagnosis, but you need to review it skeptically. The family is crucial. Very often seeing the patient, getting the patient's view of it is necessary, but it's not sufficient. That the family will have information and opinions that are crucially important. And often those opinions will reduce the diagnosis rather than increase it, because family members will be able to fill in the context in which the symptoms are occurring in ways that the patients, family member will also say, this person, my husband's under terrific stress. We're having terrible financial problems. He's afraid of losing his job. Our kid is having trouble in school. I can barely stand it myself, and I'm not surprised he's having these problems. You might not hear that same story from the patient. And sometimes it's the other way around. The family member will point out that, the person comes in, I've been fooled, especially with people who have substance problems. I've been fooled dozens and dozens of times thinking the person didn't have a serious substance problem until I hear from the family that they've been arrested 4 times for DUIs or other behaviors. You can't trust the patient alone. You can't trust the family alone. You can't trust the teacher alone. You can't trust the chart alone. But if you get a rounded view from as many sources as possible, you start being able to triangulate to what's really going on. And so I think it's crucially important to include as many accessory sources of information, but also the patient's very important. A diagnosis and a treatment should be negotiated. It's not something that we hand down from on high and say with certainty, aha, I can put you in this little box. The patient has to be a full participant in providing us with how they feel, what their experience of life is, what the stresses are in their life, the supports in their life. We need a very careful description of the symptoms. We need to know whether those symptoms are causing clinically significant distress or impairment. So the patient, and the better informed the patient is, because so many diagnoses these days are thrown out there very quickly, especially the diagnoses that are fad diagnoses, the ADHD, autism, bipolar disorder. They're thrown out so quickly by clinicians and adopted so quickly by patients that you may get, especially if you're too dependent on the chart, you may get a skewed view. I think it's very important for patients to be as informed as possible about their diagnoses, to understand, and is one of the best discussions you can ever have with a patient is, these are the problems that you're telling me about, and looks to me like this is the most reasonable way of understanding them. Sometimes the tension in the room disappears when the patient no longer feels uniquely damned or having symptoms that no one understands. Aha, panic disorder. When it happens, I start hyperventilating, and it changes the CO2 oxygen ratio in my cardiovascular system, and that makes me feel dizzy, and it makes me have paresthesias in my mouth and pins and needles in my feet and hands, and I get pounding in my chest. And this is just part of a physiological reaction to a frightening situation, internal or external. And we understand it. And very often I'll say, I almost guarantee that we're going to be able to make this better, that you're going to experience real improvement in this. And you don't have to feel terrified that you're going to die or go crazy because of this, because we understand it so well. And that moment where patients feel understood, where the diagnosis gives them an explanation for previously uncertain, terrifying experiences, that moment often, so that's one of the most empathic things you can do with someone, is to understand their symptoms and put it into context. So the act of diagnosis is a wonderful moment in many people's lives once they have an explanation that makes sense and a series of treatment options that will make it better. If the process of diagnosis is rushed and inaccurate, then the diagnosis, instead of being an aid to the patient in understanding themselves, is just another confusing element and likely to lead to treatments that will do more harm than good. So I see that act of diagnosis as a tremendously important moment in a person's life. When someone's going to buy a house or buy a car, they do lots of research. It's a careful decision because it's a lifelong, well, car's not lifelong, but a very serious decision in a person's life. We don't give the same attention to making a diagnosis than we should. There should be a special moment that comes as the fruition of a process where you really get to know the patient, they get to know you, and that the decisions made are based on a foundation of evidence, not after 10 or 15 minutes and a superficial mental checkoff. Oh, this sounds like depression. This sounds like panic. It sounds like, it should be something that requires a great deal of thought on both the patient's part, the clinician's part, and very often the family.
A very special moment, you said. And to be honest with you, that's one of the main kind of through lines that I want to get through with this whole project, is just how special this job is, how special this moment is. It harkens me to one of your reading assignments for me, Persuasion and Healing by Jerome Frank, when he talks about spiritual healers throughout the ages. And I mean, we can even think about the religious healers in the modern day. You know, you come to a powerful healer who has the vestments of the office that they hold and all of the signs of the expertise and authority that they are wielding. And, you know, as doctors, as psychiatrists, we're really not too different from that, are we? Patients come to us and we wear our white coat and we have our credentials and we have our bookshelf behind us. And it's a very charged moment and it's an everyday experience for us. But when we are placing a label on a patient from that very well circumscribed position of power, we need to be aware that we can, on one hand, help the patient to understand themselves and feel like they're not alone and feel like other people have solved these problems in the past and they're able to do so. On the other hand, if we do not give proper nuance when making a psychiatric diagnosis, we can sort of take away that self-efficacy and say, here is a label that you now have, and you're always going to have this label, and good luck living with it. I think that there's a real art in communicating that.
I think you have an art in communicating in general, Mark. That's very well put. If you're an overworked resident, seeing the 10th patient in the day, it's easy to be jaded and tired and think of this as routine. But seeing a psychiatrist is never routine for the patient. And whether that's seeing a psychiatrist in an emergency room or an inpatient service or in a medication clinic, from the patient's point of view, it's always an important moment, a moment that's fraught with anxiety, but also with hope. Even if it's a 10th patient in a day, you have to approach it with the same kind of excitement and sense of opportunity and gratitude that you're allowed into the person's life at a particularly terrible moment. And what you do and what you say can have life-changing impacts. I've had much more impact on patients I've seen in the emergency room in many instances than I've had on people I've seen in psychotherapy for 10 years. Because the moment was ripe, they were ready to hear something, they needed to hear that something, and people would come up to me years later and say, "Doc, you don't remember me, but you said this, it changed my life." And I think every contact with a patient, every clinical experience a person has during training and for the rest of your career should have with it that kind of excitement that there could be a magic moment in this contact where I can say and do something that would be very helpful to someone in a way I can't even imagine. The things we do can have very harmful unintended consequences if we do them badly. The things we do can have wonderful unintended consequences if we do them well. And we can't predict which moment will be magic with which patient. But I think we have to act like every possible moment, every moment has that possibility of being magical, and never feel I'm too tired to really give my best to this patient. That's antithetical to the reason we enter the profession. It should never be a routine job. It's a tough job to be a psychiatrist, but it's an absolutely wonderful job. I just wrote a blog that psychotherapists are the luckiest people on earth. And the main point of that blog was that we get to be better people because of our patients. That our patients teach us not only to be better therapists, better clinicians, but actually better people. And that very often we're at our best working with patients. And they're instrumental in improving us in all sorts of ways. It's not a one-way street. And so we should really feel about our profession is that we're the luckiest people to be able to do it, that no one else gets to have so many close relationships in their work life that will influence them becoming better people in their outside lives. And that makes it less likely that when you're tired at the end of the day, that you'll take for granted that you're just writing a prescription for the next patient, or that you'll do a careless diagnosis, that diagnosis you make may materially change the person's life for the better or for the worse. And it's a high responsibility to try to get it right and try to convey it in a way that will be useful, so that a given diagnosis can be very useful to a patient if it's conveyed in a certain way, or very harmful to the patient if it's conveyed in a different, less helpful way. And there should always be hope along with the diagnosis. It shouldn't just be a dire condemning, and a plan along with the diagnosis that can lead to a better life for the individual in the way they will understand. And so one of the gifts people have to have is that communication gift, which you obviously have, of being able to convey what's happening in a format that's accurate. You never want to do false hope. You never make promises you can't keep, but that does it in a cognitive reframe that makes it seem less like a condemnation and more like a kind of signal for help, that we will be able to figure out a way. If you put your heart into this and I put my heart into this, we'll be able to figure out a way to make your life better.
Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner, because this is the question bank that I used to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word Boot Camp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, Boot Camp. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Okay, so we are basing this series around when you hear hoofbeats, think horses, not zebras. And I have to give you trouble because when you write it, you write when you hear hoofbeats on Broadway. But everywhere else I've seen it, I never see on Broadway. So I haven't decided how I'm going to do that for this season. I like the showmanship of the on Broadway, so I'll probably keep it. So we're going to have our listeners learn about all of these different sort of psychiatric horses. So they're going to be learning about the diagnostic criteria, some of the first line treatments. But one of the really important points is just because someone is meeting, let's say 5 out of 9 SIGME caps, we don't give a diagnosis unless there is a clear functional impairment. So my question for you, though, is this kind of redundant? I mean, does the fact that the patient is sitting in my office as a psychiatrist mean that they have identified a functional impairment and therefore a diagnosis is mostly warranted? Do you really think there are cases where a patient does meet 5 out of 9 SIGME caps but does not have a functional impairment? And how do you navigate that conversation?
Well, first off, everyone must realize that the cutoff points in the DSM are amazingly arbitrary. So a group of people sat together in the room. I've been in millions of these meetings, and the 5 of 9 versus 4 of 9 or 6 of 9 has no particular force, especially since it depends on severity of each symptom. So if you have 3 of 9 and they're really severe, that's going to be more important than having 6 of 9 if they're really mild. The implication should be for everyone to use the system with clinical judgment, not as a rote check off. I'm going to check off this box. You have to use clinical judgment. The trouble with this is that clinical judgment is unreliable and that different people will have different ways of judging each clinical situation. We tried to build in caution by having in each criteria set the requirement that there be clinically significant distress or impairment. Now, admittedly, that's arbitrary because we don't have a way of defining clinically significant distress or impairment. It's left up to each clinician, but it's included as a kind of caution that clinically significant distress or impairment isn't just they're in my office today, that it's really messing up their lives so it's worth a diagnosis. So again, with every diagnosis, just as with every treatment, you're thinking about a risk-benefit ratio. Is giving this diagnosis so beneficial that it's worth the risks? And the risks are often unintended risks that haven't occurred to you. And one of the cautions that we're trying to provide is that don't just think about the number of symptoms. Think about how do these symptoms impact on the person's life. Clinically significant distress to me means not just they're very unhappy today, and that's why they're in the office today, but it's messing up their lives over a period of time. Clinically significant impairment isn't just that they're missing out on a few activities, it's really impairing their lives, and again, over a period of time. So this caution can't be made more specific because it's impossible to define clinically significant distress or impairment, but it is meant to be a kind of anchor so that clinicians don't jump to the idea that if I have 5 ipsy-pipsy little depressive symptoms, I'm going to make a diagnosis. That these symptoms have to be present at a level of severity that warrants them being listed as part of the criteria set for that patient, part of the making the criteria set for that patient. And there has to be sufficient duration and pervasiveness and intensity of the symptoms, so that I'm going to make the leap into the future by making a diagnosis. And if the symptoms seem to have distress, but not clinically significant distress, if there's impairment, but not clinically significant impairment, if the distress and impairment are too transient or not severe enough to require long-term attention, I won't make the diagnosis. And that's where step diagnosis comes in. Yes, you have serious problems. A lot of these problems are from the tough situations in your life. Let's see how they develop over the course of the next weeks or months. I'll give advice about certain situations that they might handle in different ways, see how that works out. And over the course of time, we'll have a much clearer picture of what the diagnosis should be and what the treatment options are. Now, unfortunately, again, if you're working in a system, you have to make a diagnosis, but you should make the least impairing diagnosis. And if you can get away with adjustment disorder, that's a very good placeholder until you know more about the patient. And it's often the most accurate diagnosis because so many people present with adjustment problems rather than clear-cut mental disorders.
That's one that I have a lot of questions about because I've run into that before where actually I was on my clerkship and the way I began my clerkship was by reading Essentials of Psychiatric Diagnosis. That is the first thing I read. A friend of mine who's a psychologist recommended it to me. And we were making diagnosis and I said to the attending, I think it's probably a bipolar disorder, but I don't see clear criteria. I'd like to use a diagnosis of unspecified mood disorder. And the attending said, well, we're putting bipolar disorder. And I kind of wanted to get into this academic debate. And he said, if we don't, the insurance companies think that we don't know what we're doing. I assume that I will understand more about that when I actually move into practice and I have these different entities kind of breathing down my neck.
I don't mind the insurance company thinking I don't know what I'm doing. I'd rather fight it out with them than label a patient with a diagnosis that may be inaccurate and haunting them for life.
Bingo.
I think that it's a good idea, and you're going to be working on a liaison service. Almost everyone on your liaison service is going to have an adjustment problem because they're adjusting to having a medical illness that may be very terrifying and truly incapacitating. And so I wouldn't be going out there making primary psychiatric diagnoses unless I'm very sure that it's not the fact that they're sick that is either directly or indirectly causing their problem, not a primary mental disorder.
Yeah, I think on the CL service, someone else is going to inherit that patient for long-term management and read your notes. So it's extra important to be a very strict diagnostician.
Especially since medication is going to be such a big factor and medical illness will be such a big factor, in addition to the fact that they're adjusting to a severe life stress and medical illness.
Just with an eye on time here, I think the final question for you will be, what do you think is the most misunderstood aspect of psychiatric diagnosis by psychiatry residents today? Is there anything you feel like you haven't said yet that you think any psychiatry resident must know before they start writing diagnoses on patient charts?
Well, I wrote a whole book on that, but I guess
yeah.
The major thing, and it's just repeating what we said before, is to be cautious, to think about the long-term impact of the diagnosis, to not just focus on its benefits or the fact that it may be accurate, but to also think about the fact that a diagnosis can cause harm over time, and that the unintended consequences that don't occur to you are a long tail of dysfunction for the patient. So the care, the better you know your patient, probably the less severe will be the diagnosis you give. And so you can't, in this insurance company controlled world, write your diagnosis in pencil, but you should always underdiagnose. You can always increase the severity of diagnosis as you know the patient better. Always underdiagnose at the beginning rather than jumping to conclusions that may cause great harm over the long run for the patient.
Well, thank you for being so generous with your time with me this morning, and I look forward to talking to you next.
Always. Thanks.
Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.